Great. Hello, everybody. I'm just going to give it a few more minutes. Well, we're 11:59, so let's give it a minute or two. And I can see numbers are going up there, but thank you all for joining so far. We're very much looking forward to the webinar this morning. And it's a lovely bright morning here in London. I don't know what it's like with everybody else. Rebecca, what's it like up in Sheffield?
It's cold, but it's beautiful, beautiful blue skies. So yeah, it's been really nice up here.
Good. Stacey?
Yeah, also the same. Nice blue skies and all fine here.
Great. Okay. Rue, how is it for you?
It's gorgeous and sunny.
Oh, good. Okay. Well, a few more people are joining. I always like to give everybody a chance. We're getting some nice hello messages in our chat, so that's also nice to hear from people. Yeah, we've got two so far, so please feel free to do it. Yeah, the numbers are going up, but I think that it's important that we start. So I will do that. And really, just to say good morning to everybody who's here. Thank you so much for joining us for our Preventing Gynecological Cancers webinar today. It is Gynae Cancer Awareness Month. And I'm very excited that today we will be launching a powerful new campaign to expose life-threatening gynecological cancer inequalities, which it's terrible to think that every day 21 lives are lost to gynae cancer, and that those who come from ethnic minority backgrounds, communities living with disabilities, neurodiversity, and many more face far greater barriers. So I'm very excited that we will be launching that campaign today. And I know that we're literally waiting for the film. So, and as soon as I get the thumbs up that that's ready, I will let everybody know. But if it's not ready by the time we finish the webinar, it certainly will be by the end of today. So joining us on the webinar this morning are Miss Stacey Bryan, consultant gynaecologist and gynaecology oncology surgeon at Imperial College NHS Trust. GP Dr. Rebecca Mawson in Sheffield, who's also a clinical lecturer with the NIHR, and Rue Grewal. Thank you so much, Rue, for joining us this morning. And Rue has kindly agreed to share her experiences of her gynecological cancer diagnosis. So during the webinar, we're going to explore a number of different topics and themes. We're going to talk about what are gynecological cancers and what are the symptoms, what we can do as women to reduce our risk of developing a gynecological cancer, all the different screenings that are available, and how we can make them more accessible. What I'd like to let everybody know is that the webinar is being recorded, that there is every opportunity to write your questions and comments, and we really welcome those throughout. So please use the chat function. And we will be sending an evaluation survey after the webinar. And I really do encourage everybody to fill it out, please, because what that does is it helps us to make improvements to our future webinars. So if you have got any comments on what we could do and how we could make things better, please do fill that out. So again, welcome to everybody. I apologise that many of you were expecting to have our chair, Professor Dame Lesley Regan, leading this. But she called me with only a few minutes to go to say that she had been called to an important meeting and that she would have to step away today. So she does send her apologies, and will be, normal service will resume for our next one, but just for today, you've got me. So as I say, I really am so pleased that we're able to do this event. Over 22,000 of us will be diagnosed with a gynecological cancer every year. And it's thanks to the better understanding and indeed some of our research that goes into how cancers develop and causes and all the rest of it, helps us to make sure that many women who are diagnosed get the treatment they deserve, and indeed that many women are now prevented from getting a gynecological cancer. But I think the most important thing for all of us is how can we reduce our own risk, and how can we make sure that any changes in our bodies are caught early, because we all know that when you catch things early, that treatment is so much better. So we will be covering all of that this morning. But without further ado, I would like to invite Rue to talk about her situation, what's happened to her over the last few years, and what will be happening in the future. So Rue, can I pass over to you, please?
Thank you, Janet. And I will start off with an apology in advance. I'm having internet issues and my video goes off. It's gremlins. So please bear with. Actually, let me start where I am at the moment. I am diagnosed with stage 4 clear cell ovarian cancer. And my journey really begins back in officially 2017. And I'll tell you what I mean by officially. If I look back, and I write a diary with my journey, when I look back at my diary, I think my journey really started when I started getting period issues, and it goes way back. Every time I sort of went to the doctor, it was always fobbed off, but I suffered with painful periods that just got progressively worse. And before I got my official diagnosis, I went through a very terrible 2 years with all the symptoms of ovarian cancer. The bloatedness, the losing weight. But when you're losing weight as a woman, you think, yeah, great, because I'm going to the gym, fantastic, it's working. But my periods got worse and worse, and they were debilitating. And I kept going to the doctor. I'm not one of these people that sort of sits back and just ignores it. Every time I had a painful period, I went to the doctor. And unfortunately for me, it was fobbed off. I think that they went through sort of A to Z, but sort of missed the C, as the C letter, where it had cancer. And I never even imagined it would be cancer. I don't do Dr. Google. I never imagined it would be, because cancer never ran in our family. I saw a locum doctor, and it was a locum doctor. I had various other symptoms, like I was very anemic. I thought the only way I could be anemic is because I was losing blood through my period, no other way. Anyway, all these little things that didn't really add up. And it was a locum doctor that sent me to the first examination in 2 years and said, I think you may have fibroids. Let's go and get you investigated. And that started in 2016. And it took 6 months. I'll never forget this, just before Christmas, before someone said to me, we think you've got cancer. And then 2017, I saw a wonderful professor who virtually saved my life, Professor Christina Fotopoulou, who was Imperial Trust, and then it just went from there. At the diagnosis, I didn't have time to save any eggs. She was fantastic at a bowel resection. And there was a moment when she came into my room and she was sort of waking me up, and she sat there and she squeezed my hand. So I get very emotional telling this because I can still tap into that feeling. She said to me, you must have been in so much pain for so many years because you were an absolute mess inside. Still gets to me, because it took a doctor to open me up, to tell me what I have been saying for years and years and years. And I was absolutely covered with endometriosis. She She told me if you were trying for a baby, which I kind of was, and couldn't get pregnant, that was the reason why I wouldn't have been able to carry a baby. And there, my journey starts with clear cell ovarian cancer. 2 weeks later, when you go in and take your stitches out after your hysterectomy, the results came back that I did have clear cell. And at that point, I was stage 1. I still had to go through chemotherapy. That was tough. I had a TIA. I couldn't take one of the drugs. You lose your hair. I mean, everyone knows, it's well documented what cancer treatment looks like. And then that started my journey. Fast forward, because I could talk about this all, I could take the whole hour talking about my journey. I now try and advocate and I'm here with stage 4 ovarian cancer because of a lot of the work that I've done myself and a lot of research I've done. And in this day and age, with the internet, with Facebook, with being able to get hold of doctors all around the world and linking up with other women, you can get the knowledge that you need to have more meaningful conversations about the treatment that is out there for you. You know, I had immunotherapy that saved my life again. So after COVID, when my cancer came back, by getting in touch with Merck, the company that has immunotherapy, the Keytruda, that's bought me some more time. The knowledge is out there. And I became a district councillor when I wasn't working, with a view of getting a platform to talk about women in our community who are clearly suffering, who are not getting the answers that they need, or being fobbed off because the knowledge isn't out there, to be an advocate for your own well-being. And I'll say to anybody, and Janet mentioned this, you know your body. And when you know, you may not know the answers of what is right, but you know when you feel off and you can't quite put your finger on it. Number one thing I'll say to any woman, and I'll say to anybody actually, go and find the doctor that listens to you. If you don't get the answer that you need from somebody, go and find somebody else, and go and find somebody else until somebody actually listens to you and you start going through the tests. All anyone had to do was give me a CA-125 test. It doesn't cost a lot of money. And they would have, okay, it wasn't elevated as much, but it was elevated beyond the baseline, enough to warrant investigations. And my story could have been different if I had been listened for the last 2 years before I went there, and investigations had done transvaginal tests and all kinds of things. It was all there. And I think when you get the diagnosis and you knew something wasn't right, it becomes a tougher journey when you have to face cancer, with all what that entails. So that's number one thing I would say to people, that you know your body, go and find someone who listens to you. If you don't feel that what the information you're getting back is correct, go and see somebody else, because getting it early is absolutely key. If you do go through a cancer diagnosis, find your tribe. It's my tribe that got me through the bad days. You will help somebody else in that journey. The information that you get, the knowledge that you get, the experience you can pass on is so key to people. I'm on loads of Facebook, loads of groups, and I can see people struggling. I was there. I had no idea. I didn't know where to go. You are managing not only your own emotions, you're managing everybody else's emotions. There is the help. Go and get it. Don't be afraid to ask for help. It's a difficult journey, but I'm living with stage 4 cancer. And the reason I'm living with stage 4 cancer is because I've gone on and found out, and I've been an advocate for my own health. So that's, you know, whether you need counseling, whether you need nutrition, where you need to understand how cancer sort of is in your body, what fuels it, what lifestyle changes you need to make. The answers are there, and you just need to empower yourself. So I'll stop there, because I could talk about this forever and a day. But that's number one thing I say: go out, get that knowledge. You know your body, empower yourself with the knowledge. Be an advocate for your own journey. Talk in tandem with your doctor. Be honest with your doctor, and you will get through. You will get through. I'm testament that I'm still here, and I have no plans of going anywhere, so I'm still here.
Rue, no, I mean, I don't know if you're looking at the chat at the moment, but I have been, as you've been speaking, and everybody is thanking you for sharing what is an incredibly difficult journey that you've had so far. And we are obviously delighted that you're still here. Thank you for sharing some of your, I'd say, tips, which are, don't take no for an answer, and really try and educate yourself and equip yourself with all the information, and to find your tribe. And one point that I thought really resonated there was that you've got to find the right tribe for you to support you, because also you will be supporting other people who won't know what to do and what to say. And one question I have for you is, um, uh, you're a great advocate for what we want all of us to do, which is to feel that we have got that right information. How do you think, if perhaps people, are they're finding it more difficult than perhaps you would to go out and research and everything? What do you think they might be able to do to make that easier for themselves? I think we might have lost Rue. Oh no, we're back. Did you hear my question, Rue? No? Okay, well, I think what we'll do is we'll come back to that, but I'm now going to hand on to Dr. Mawson, Rebecca Mawson. And I wonder if you would sort of really talk to us about what are the gynecological cancers, give a sort of good overview, and here are your slides. Thank you. Over to you then.
Thank you. Gosh, I don't quite know how to follow that, Rue. That was incredibly powerful, and a sort of real privilege to listen to your story. I also feel like I should apologise for my own profession, that you felt fobbed off, or you were fobbed off when you went for symptoms, and that's something I hear continually with the research that I do. Now I'm just going to move my screens around a little bit because I'm going to be not looking at you when I'm going forwards, but can everyone see that clearly? Because I'm just trying to find my my visual bit. But so the screen, are my slides now big on your screen? Let Janet, fab. That's great, because my only slight problem is I don't know how I'm going to move them on. We did practice this, but one second, I'm just going to come back and reshare. They're not coming out where I can see how to share them. Sorry, everybody, for technical dramas. Yeah, it's still. Right. I'm just wondering how I can click them forwards. Hold on. Sorry, everybody. This is fun and games of. We just practiced earlier and it was absolutely fine, but let's see if this will work.
Helpful tips from the chat. Somebody said you need to be in slideshow mode.
I wasn't I thought I was, but keep the tips coming, guys, because it's just meaning I can't. If I'm on two screens, it means I can't see how to click it on. Got it. Right. Thank you very much, whoever gave that tip. You can come with me to all of my presentations because that was super helpful. So I'm just going to begin. So sorry again for the technical dramas. I promise I'm better GP than I am a technical person. But I just wanted to start off by just thinking right back to basics about what cancer is. So sometimes we talk about cancer and maybe don't necessarily think about what we actually mean when we're talking about cancer. So cancer is when the building blocks, the tiny little cells within our body start to grow completely out of control, completely erratically. And that can be in a local area, so it can be in one place, or it can spread to different parts of the body, which is when we talk about things metastasizing, so moving to different parts. And what we're thinking about when we're talking about gynaecological cancers we're talking about cancers specifically related to the female reproductive system. So I've got this sort of T-shaped uterus and ovaries and vagina kind of in the picture, and we're going to kind of move through talking about the different parts of the body as we kind of go through today. So these are the 5 cancers that I focus on today for today's talk, and we're going to run through them one at a time. Think about how many people are affected by them in the UK, and then think a little bit about the symptoms. So starting off, we're going to talk about uterine cancer, so womb cancer. Now this is the one of the most common gynecological cancers that we see. So there's around nearly 10,000 women diagnosed each year in the UK. It's the fourth most common cancer that affects women. So there are other cancers that are higher up, but this is the most common gynecological cancer. Now, it predominantly happens in women who are older, so over the age of 70, 75, but we are seeing it happening more and more commonly in younger women, especially as we see increases in people being in larger bodies, which can impact your risks of getting different types of cancer. So focusing more on the symptoms, so these are the symptoms of womb cancer, uterine cancer. One of the things that we would count as a red flag is if you've gone through the menopause and your periods have stopped, any bleeding that happens 12 months after that is what we would call a red flag, and that needs urgent investigation, because we don't like seeing bleeding after you've had a long gap without bleeding after menopause. The other thing we want to see people with is if they're having a change in their periods. So if the periods are becoming more heavy or they're starting to get bleeding between their periods. Now, the slight challenge with that is that also happens during the perimenopause period. So we do see that even when it's not related to cancer, but it's something, any change we do want to be talking about what might be causing it. If you're having vaginal discharge, so especially if there's blood mixed within the discharge, that would be something we'd worry about. New tummy pain, so new abdominal pain or new swelling, like we talked about, the bloating or change in bowel or bladder are things that we want to talk about and start investigating. So moving on to ovarian cancer, which Rue's already talked about. Now, this is the one that keeps me awake at night. So this is the one I'm terrified of missing, because it's something that has such a huge impact, and it's also a cancer that happens inside the body. So there's less outside evidence of what's happening, and often the symptoms can be quite vague, especially at the beginning, but it affects around 7,500 new diagnoses each year. So it's the sixth most common cancer that we see in women, and the risk of developing happens as you get older, and the greatest risk is between 75 and 79, but there are women a lot younger that are affected by it. Now, one of the problems with the symptoms of ovarian cancer is that they are very similar to lots of other symptoms we see, things like IBS, different types of changes that we see in women, especially through perimenopause and menopause. But classic things around pain, abdominal pain, swelling, changes in the appetites and not feeling hungry, bladder changes, fatigue, tiredness, bowel changes, that weight loss and kind of just feeling full, not wanting to eat very much, indigestion. And, we do see this sort of change in vaginal bleeding as well. So moving on to cervical cancer. So cervical cancer, so your cervix is the lower part, the sort of neck of the womb, and the bit between the vagina and the womb is your cervix. Around 3,300 are diagnosed in the UK each year. One of the things to flag up with this cancer is that it's one that affects women in their 30s. So it's one of the more common cancers that we see in younger people. And I'm sure Stacey's going to talk about this a bit more in more detail, but with cervical cancer, what we have is this diagnosis called CIN, or cervical intraepithelial neoplasia, if you can get my teeth around that. So that's a pre-cancer. And what that means is that the cells on the top layer of the skin have started to change and started to multiply, but they haven't breached into the kind of below layers, the kind of protective layer. And that's something that's treatable, and it prevents moving on into cancer. And we know there's this strong link with cervical cancer and HPV, or causative factors, that I think Stacey will talk about shortly. So the symptoms that we think about with cervical cancer, so because of where it is in the body, it's the top of the vagina, what we sometimes see is change in bleed patterns, spotting, bleeding between periods. But one of the notable things is bleeding after sex. So if you can imagine penis and vagina, there might be irritation to the cells that might be changing at where the cervix are. You might have pain, discomfort during sex, or there might be discharge. And I always make people aware of that discharge mixed with blood is something I really, really don't like at all. In more advanced stages, you might get pain within the pelvis and within the hip bones. Now, the thing to mention is that all of these symptoms also are many, many symptoms of other things. So things like, it might be chlamydia and different infections that can cause these. So having these symptoms doesn't mean you've got cancer, but it does mean you need to get checked out and you need someone to have a look at your cervix, which is really, really important and sometimes doesn't happen in general practice setting. Second to last, I want to talk about vulval cancer. So the vulva is the kind of skin bit on the outside of the vagina. So where you have your labia, the lips of the vulva, and it's a cancer that we see in about 1,400 people each year. So it's relatively rare. We're kind of coming down the kind of common list, but it's something that's really important that we're aware of. We tend to see it more in women over 75, and it's also like cervical cancer. We have this pre-cancer, and if we pick up early, we can treat it and we can kind of prevent it progressing on into further cancer. Now, symptoms wise, and that's why I put a picture of a vulva with a mirror to remind me that everyone today, I want you to get your mirrors out and have a look at your vulvas, because what you need to know is what your normal is, because what we want to know is when things are different. All vulvas look completely different, as I'm sure Stacey will agree. They all look completely different, and so what you want to notice is a change in the skin of the vulva that when you have a look. So if you have any sores or any visible changes to the skin, an itch that just keeps causing you trouble, doesn't respond to treatment with thrush treatments or estrogen if you're in the perimenopause. If you notice any bleeding from the vulva, pain, soreness, thickening, like you can get these sort of white thickening bits, dark thick bits, moles that change, or definitely if you get any lumps in the groin, when we think about lymph nodes, thinking about spread to different parts of the body like we mentioned. And to finish, I just want to talk about vaginal cancer, which is very, very rare, but it is worth us just mentioning. So there are around 250 women diagnosed with it each year. Tends to be in women more over 75, and it's slightly similar in terms of presentation, in terms of bleed changes. Might notice changes after sex. That vaginal bleeding that has blood in it, vaginal discharge with blood in it is really key. You might feel a lump, you might feel something that feels sore or uncomfortable. Any swelling around the vulva might be suggestive of something higher up, or pain kind of in the pelvis that is new. So those new changes are really, really key to kind of pick up and seek help early on. And so just to finish, I did want to flag up that we focused on gynae cancers today, but this is a list of the top 10 cancers that affect women in the UK. And breast cancer, lung and bowel are the top 3. Now, breast cancer we have screening for, and we have bowel cancer screening, and we are about trying to look at lung cancer screening. So it's just a flag up that yes, we do want to focus on gynae cancers today, but do go for your screening for the other types of cancers that do also affect us as women. And I'm going to finish there and hand back and see if I can actually get out my slideshow. Give me 2 ticks.
Lovely. Rebecca, that was so informative and really helpful. Obviously, because there is so much overlap and there are some general symptoms that mirror symptoms for other things, of course, it can be quite confusing. So do you recommend that women keep a diary so that they can see if the symptoms are sort of a one-off or they keep coming back? I mean, I'd be quite interested on that, to know your thoughts on that.
Yeah, I mean, I sort of get a bit frustrated that we have this. We need to get women to sort of prove their pain or prove their symptoms or prove something to get something to action. I'm very keen on my patients just telling me that something has happened. It's different from how they're normal. That is enough for me to take that forwards. The problem is that I see these type of symptoms we've talked about in this session. I would say I mainly see women now in my general practice. I'd say I see these pretty much in every appointment, and I see 28, 30 odd patients a day, and very rarely do I pick up on cancer. And so what we need the scientists and the brilliant people that work at Wellbeing Women to come up with easy diagnostic tools so that we in general practice can diagnose things right at the beginning, whereas I think GPs get, and practice nurses sometimes get a bit overwhelmed by symptoms and not quite sure how to pick out the ones that are, you know, red flags. And when you're, you know, and I think that's, I think, one of the biggest challenges. But yeah, any change to me is enough. I don't need to keep diary. I just want to know if something is different, and that's enough for me. But yeah, I do hear stories of people having to prove the difference, prove the change in bleed pattern, or prove the bloating, to get people to notice it. But yeah, I think just being an advocate for there's been a change is really key.
Rebecca, thank you for that. It's very, again, very helpful, and I'm sure that everybody here would agree that it would be lovely to have you as our GP.
I am rubbish at diabetes though, or epilepsy, so as long as it's women's health, it's fine. Just don't come to me for anything else.
Okay. Stacey, can I bring you in now? Is that are you able to do that? So as I said earlier, I think we're incredibly lucky to have Miss Stacey Bryan with us, who, you know, is a consultant gynecologist, but also an oncology surgeon, a gynaecology oncology surgeon at Imperial Healthcare Trust. So I would like to hand over to you, Stacey, and you know, maybe you can talk a little bit more about what causes gynae cancers, how risks are managed, risk factors, cervical screening, and there's so much to get through. But if I can hand over to you, that would be great. Thank you.
Yeah, no. Thank you, Janet, and thank you to the Wellbeing of Women and team for inviting me as well. Rue, thank you for your fantastic talk as well, and Rebecca for the information, which hopefully sets the scene for this next segment on looking at risk factors for gynecological cancers. As Janet said, it's a lot to cover, so kind of trying to do a whistle-stop tour through it. But hopefully at the end with the question and answers, feel free to put things in the chat, or at the end, raise a hand, or we can get some dialogue, however it will work, and hopefully I can answer some that may not have been answered. So when I look at risk factors for gynecological cancers, I'm just sort of breaking it down into different types of groups. And the first thing to look at is lifestyle, and that's just in general risk factors for cancers in general. The biggest one, though, for when we're looking at cancers, gynecological cancers, is being overweight, so increased weight, high BMI. And this is because, and this is a big risk factor for endometrial cancers in particular. And this is because those who have a high BMI, who are overweight, have high levels of estrogen within the body. Now, estrogen and progesterone are your natural hormones within the body, but if there is any form of imbalance, and i.e. an estrogen dominance, it can affect the lining of the womb. That can cause thickening of the lining of the womb, which if you're not treated, not looked at, can go on to lead to endometrial cancers in particular. So obesity is one of the biggest risk factors. The other thing is smoking. And again, in general, smoking stops the body's DNA from being repaired in the certain processes. So it means that there's more chances of what we call mutations within the DNA, meaning that cells grow rapidly and divide quite rapidly and lead to cancers. For us, again, with gynecological cancer, smoking, we see that more of a big risk factor for cervical cancers. And this is because, as mentioned before, HPV is the biggest risk factor for developing cervical cancers and cervical pre-invasive changes. And smoking actually prevents the body from getting rid of HPV infection. And I'll go on to cervical screening and HPV a little bit later. So smoking is one that we advise to really cut down on or even stop. And vaping, actually, we find, and there's a lot more studies looking at that vaping also has a similar effect in terms of preventing the body from getting rid of HPV infection, and therefore putting you more prone to cervical precancer changes. HRT is another thing that we kind of see and look at now. With HRT, again, the hormone replacement tends to be your estrogen and your progesterone, and largely based on all the studies that we've got, A lot of the potential risks definitely are outweighed by the benefits. I would never say not to have HRT if you need it. But one thing to be aware of is sometimes when there are changes in the dose of the HRT, so that again, the estrogen component, making sure we match that with the progesterone component, because if you have too much estrogen, again, it can affect the lining of the womb. And I think I was just trying to keep up with some of the questions in the chat to see if I can answer them as I go along. But I think someone had questioned when Rebecca was talking about the different symptoms that you have, i.e. postmenopausal bleeding, does it apply if you're on HRT? So yes, I would say if you've been on HRT for a period of time, you've been stable on that, and you have new onset bleeding or bloody discharge as was described, then definitely go in and see your GP and have that looked at, because it may be that the dose is a bit imbalanced and we need to really have a look into that. The next kind of broader category is genetics. So gynecological cancers can have a genetic component to it. The two main ones being, I don't know if you may have heard of the BRCA genes and the BRCA gene mutations. So BRCA, there are two types of genes, 1 and 2. Most commonly, you may have heard this associated with breast cancers, but actually mutations in these genes can also give rise to ovarian cancers. And also, again, the theme of just looking at cancers in general, but also prostate and pancreatic cancers. It's been seen that mutations can give rise to those also for the men as well. The other big genetic risk factor is something called Lynch syndrome. So we now normally see genetic defects with Lynch syndrome, which are associated with bowel tumours. But actually now we can see that in endometrial cancers, so womb cancers, some of our patients have these gene defects which are linked to Lynch syndrome, which again also puts you at higher risk of developing endometrial and ovarian cancers. So much so now that anyone who has a new diagnosis of womb cancer or endometrial cancer, we actually test for the genes within the tumours to see if they have what we call mismatch repair, so a mutation within these genes, and therefore then need further testing for Lynch syndrome, because of course these have implications for family members as well. A strong family history, so in the absence of those particular gene mutations, if you have a strong family history of breast cancer, ovarian cancer, bowel cancer, then that would also be a reason to see a geneticist, for example, to have a look into your potential risk factors for endometrial and ovarian cancers. There are different tools that are available on websites nowadays where you can actually type in your specific age, family history, risks, etc., to see what your potential risk could be if you do have a strong family history. Moving on to sort of the next category, it's looking at other gynecological conditions which may give rise to cancers. So late menopause or having an early menstruation or starting the periods early may give rise to put you at further risk of developing ovarian cancer and endometrial cancer. And again, it's about having exposure to hormones for a longer period of time compared to those who maybe have an earlier menopause or who started periods a little bit later. Similarly, those that have never been pregnant. So the theory being that when you are pregnant, you have a delivery. If there are any abnormalities that potentially may have been brewing in the lining of the womb, for example, these are shed during delivery, and you don't necessarily get so much. It seems to be protective from some of the studies that we've seen by having had a pregnancy in the past. Polycystic ovarian syndrome, again, because polycystic ovarian syndrome can lead to an imbalance in the hormones. Sometimes you get a more estrogen dominant profile, so high levels of estrogen. Again, that puts you at risk of developing what we call hyperplasia, so thickening of the lining of the womb. Again, if left untreated, then cancer of the lining of the womb as well. We've heard already from Rue. Rue had a background history of endometriosis. So endometriosis, for those who don't know, is when you have tissue that's within the lining of the womb that may be present on different parts outside of the womb, so over the uterus itself, on the ovary, in the lining of the abdomen itself. And unfortunately, some cases of endometriosis can turn into an aggressive type of cancer called clear cell cancer, which is exactly what Rue had described earlier in her story. So yes, it is rare, but there is an association there that clear cell cancers can arise from endometriosis. And then lastly, in terms of other gynecological factors, we have to mention fibroids. Again, fibroids are usually benign growths of the muscle layer of the womb, but in less than 1%, these can turn into what we call sarcomas, which are cancers of the muscle of the lining of the womb, and they can be quite aggressive. So if anyone who's living with fibroids, majority, like I say, over 99% will be benign and nothing to worry about. But if you do have a fibroid that's suddenly fast growing, giving a lot of symptoms, a lot of pressure symptoms, a lot of pain, that would be a red flag to kind of go into the GP to have that investigated. Moving on to age, so again, it's already been mentioned that as we get older, cancers become more common, unfortunately. Part of that is to do with, again, the body and the cells and the DNA changing and not being able to repair themselves as efficiently as they did when we were younger. But part of it is, and that's what we call sporadic mutation. So it's not related to any genes, any family history. It's just an aging process, unfortunately. But there is another thing when we look at the context of vulval cancers, for example, which tend to affect the older population or generation, something called lichen sclerosis, which is an inflammatory condition of the skin of the vulva, of the labia, which usually presents with quite intense itching, particularly at night, burning, redness, which again, if left untreated, can then go on to be a precursor to vulval cancers, for example. Again, very rare, but something that not a lot of people are aware of, and an important reason why we need to be aware of our bodies, as Rebecca has alluded to before. Other things are weakened immune system. So similar to how smoking prevents the immune system from fighting off any infections or any changes in cells, HIV, AIDS, any immunocompromise can also put you at risk, particularly of cervical cancers in particular. And also, again, it was alluded to these pre-invasive diseases. So changes that occur that we can pick up before things become cancer. So in the cervix, it's called CIN. With the vulva, it's called VIN. In the vagina, it's called VAIN. And these are changes that can be seen when you have your checkups for patients who have these disorders that would need to be kept under control and regular monitoring that can be treated before they even turn into a cancer. So then what can we kind of do in terms of prevention as far as possible? Again, Rebecca's already mentioned the self-awareness and examination. So as much as we talk about, doing your breast examinations once a month after your period, etc., to make sure that there are no lumps, bumps developing. I'm actually glad Rebecca showed the image with the mirror as well. So one of my other hats is that I do a vulval clinic. I run the vulval cancer clinic. And to all my patients, I say at least once a month. Again, in the chat, I think I saw someone had said there's a group that advocates once a week. Whatever works for you, but at least once a month with a mirror after you've had a shower, have a look down below, see what your normal looks like, because as Rebecca said there, vulvas, labias look so different. Within a person, they could be asymmetrical, one longer than the other. There's so many different ways in which vulvas look. And so knowing what your normal is much easier to then to come to your GP, to someone like Rebecca, and say, I've noticed that a change over the past, I don't know, month, 2 weeks, however it is, it's now more red, it's now more swollen, an ulcer has developed, and therefore these can spark the red flag symptoms within the GP's mind. Okay, this needs some further investigation. This needs possibly a biopsy, for example. So really about self-awareness and self-examination. Seeking help from the GP if there are any unusual symptoms. And again, if you feel you're not being heard, go and see someone else, ask to see someone else, persist. But also because in your body, keeping a diary as mentioned before, then being able to say, look, this wasn't there beforehand, or I didn't have this symptom beforehand. Please, this is what I'm experiencing now. I'd like to know what's happening. The other thing to talk about, so I mentioned about genetics, so the BRCA gene and the Lynch syndrome. So there we do have genetic clinics or genetic counselling clinics where we talk to patients about what we call risk-reducing surgeries. So in the context of the BRCA mutations, which gives you a higher risk of ovarian cancer, for example, we may talk to women about having the ovaries removed before there are any cysts or anything that have developed. And usually at a time where you know, if they're wanting children, they've completed the family. If they don't want children, then fine, we'll have those discussions there. It's usually offered over the age of 45 because, of course, removing the ovaries can put you directly into menopause. So those factors will be discussed. Likewise with Lynch syndrome, there's a program now where we're monitoring almost yearly, taking a sample from the lining of the womb just to make sure that there's no development of any pre-cancerous changes or cancerous changes in the womb related to Lynch syndrome. And again, similarly offering what we call a prophylactic hysterectomy or risk-reducing hysterectomy for those patients who are at high risk. Lastly, in prevention, it's about engaging in the screening programs. Now, unfortunately, the only screening program that we have for gynecological cancers is the cervical screening program, fortunately or unfortunately. Fortunately, in this sense that if you do have your cervical screening, it has been shown to reduce sort of the risks of the development of cervical cancer. The idea behind the screening program is that you're detecting these pre-invasive changes so that they can be treated before it even becomes a cancer. Now, the program in England in particular, you're invited at the age of 25 and it runs into the age of 64. And what we look for now is HPV, so human papillomavirus, which the majority, over 80% of us, will come into contact with if you're sexually active. So spread by skin-to-skin contact, sexual contact, etc. We now look for HPV. If someone is HPV positive, then we look at, has the HPV started to affect the cells on the cervix, so what we call these precancerous changes, and if so, to what degree. If it's to a low degree, we can just monitor this possibly yearly. If it's to a higher degree, then we would be offering treatment. So as I said, it doesn't then go on to progress and turn into a cervical cancer. So really engaging with the cervical screening program is important. The caveat also to that is also, of course, we've got the HPV vaccination, which has been is offered to those of school age 12 to 13 before they even come into contact with HPV. The idea being that when they do become sexually active at that age, they at the age of consent, then their immune system is able to fight off HPV and it's less likely to cause these precancerous changes. And we've already seen that this has reduced the risk of cervical cancer by about 90%. I do a colposcopy clinic, and a lot of the changes that I do see, the referrals in, tend to be the lower grade changes that we often can monitor. Very rarely now am I seeing the high grade changes that need surgical treatment or treatment to the cervix. So we know that these programs do actually work. Another thing just to cover within that, again, I think I saw in the chat, or someone was saying, is cervical screening enough to check? I think you meant to check all gynecological cancers. So just to be clear, cervical screening will only check for the cervix. So if you've had a normal cervical smear, it doesn't mean that we've checked your uterus or we've checked your ovaries, and that means that you're clear of all the other gynecological cancers. So it's just to be clear, cervical screening is only specifically related to the cervix, as that's the only screening program that we have, effective screening program that we have in gynecological cancers at the moment. I know time is running, so I'm going to stop there. But the key really in terms of prevention is about self-awareness, examination, and please seeking help from your GP if you do have any of the unusual symptoms that were described before. Thank you very much.
Wow. Stacey, that was amazing. Thank you very much. I cannot tell you, we've had so many questions. I'm going to start with the first one, which is, what do Rebecca and you, Stacey, feel about the change from 3 years to now 5 years for cervical screening?
Well, yeah, I mean, it's something that we've actually discussed quite a lot in our in my GP clinic, because I think there's quite a lot of alarm with our practice nurses and reception. I think I guess I see what happens behind the scenes from my academic job of what goes through the screening to try and change or adapt screening programs. And there's quite significant science and evidence behind why they've done that. So even though it feels, you know, I'm someone who's always had HPV on my smears, I felt quite alarmed that I was going to be going to slightly longer, potentially, you know, could be going to longer time. But I feel reassured that there is science behind why they've made that decision. And as Stacey's mentioned, we will still be those of us who have high risk HPV will still have the follow up that we need and be aware of what to do next. My thoughts.
Stacey, anything to add?
Yeah, so it's just to what I would add to that is just to be clear that the move to 3 year, as far as I recall, the move to 5 year are those who are HPV negative. So we know that if you're HPV negative, so HPV causes 99.8% of cervical cancers or precancers. So if there is no HPV, you're very, very minuscule risk of developing a cancer. And actually, from contracting HPV infection to developing cervical cancer, it's like 10 to 15 years. So waiting that 5 years, again, as Rebecca was saying, based on the evidence and, all the research and everything that's gone into it. And again, because we've had HPV vaccinations, etc., and we're seeing more lower grade changes, waiting that 5 years appears to be safe to be able to do that rather than having to have it every 3 years.
Okay, great, thanks. We've had quite a lot of questions on dietary and lifestyle advice to reduce odds of getting different gynae cancers. And actually, we had a question in before. It was a pre-submitted question about somebody who is celiac and immunodeficient and has been struggling to fight off HPV and wanted to know what she might be able to do to help her fight off HPV. So, and there are others in the chat about sort of diet, lifestyle, etc. So I don't know if one of you wants to pick up on that.
I was going to say, well, Rue might have some. Rue, I think you probably got the most knowledge on that from a self perspective. If you have any thoughts.
Well, when I finished my cancer treatment, I think when they say well done, you ring the bell and you go home. And I think what I was left with, what do I need to do to make sure it doesn't come back? And that's when the research started, and COVID helped me in that respect because we all got locked in and we had nothing else to do. And it was quite interesting. There's lots of debate about whether sugar feeds it or not. I'm not going to go into the ins and outs of that because I'm not a medical doctor. But I think just do your research. I think we know when we're eating the wrong foods. I don't think we need a textbook to tell us, you eliminate processed food, you try not to get food out of packets and tins and eliminate plastic. And the more research you do, the more you kind of realize, I'm probably not giving my body the best things to be able to fight whatever it is that you get. We're compromising our immune systems. So I'm not going to go into sort of HPV and all of that because that's not my domain. But I would say own your health. Once you get through the treatment and you get through the other side, go into whatever research you need to do and make those lifestyle changes. Stress is a great one as well. Mindfulness, meditation. My whole life opened into all.
Rue's camera's frozen.
Yes.
Oh, yeah. Sorry. I was just going to jump in and say one of the things I say to my patients is it's all about balance. It's all about, you don't want to be picking something that's going to make you feel really stressed because you're trying to stick to this really specific way of life. And I think one of the things I fear, especially with some of the social media trends and some of the TikTok videos that I'm seeing, is that influencers are prescribing these absolutely outrageous diets to cure your cancer, and we've got to be so cautious not to let that noise sort of overwhelm us and just focus on that balance of trying to do what you can with the resources that you have. Not everyone can afford to live to eat sort of as healthily as we'd want to, but so it's about what you can do, small measures that you can do every day with exercise and with as much as back to natural as possible. It's kind of what I advise.
I think that's really valuable advice, Rebecca, that there are so many things out there that just aren't correct, and so getting information from your healthcare professional, whoever is treating you, from your cancer nurse if you have one, specialists obviously like Tracy, and it is all about balance, and not everybody can go and purchase lots of different things, and anyway, they're probably not worth it. So it is really about eating as much fresh food as you can and really keeping a balanced diet. Other questions that we've had, and I know we've only got a few minutes left, but if we can sort of cover these two together. There's a lot of chat about HRT and gynae cancers, and I know that's an old favourite. So just your thoughts on that would be really helpful. And then there's I know you've covered the endometriosis and the cancer one, but how can you really advocate for getting genetic testing if you've a family history and you're not and nobody is sort of helping you do that? Just any thoughts on that? The last two questions, please.
I can speak for the HRT part. So just to sort of reiterate and clarify, we know from the studies now that the the benefits outweigh the risks, should I say, of taking HRT and managing symptoms for menopause. As I said, though, so we wouldn't say don't take it because it increases your risk. It's when they look at the background risk in the general population for developing gynecological cancers, it's not that much. What I wanted to try and kind of get across is just making sure that there's the right balance of the hormones so that you're not having more estrogen, for example, than the other, making sure that there's more progesterone protection if the estrogen component of the HRT is increased. So long as you're, seeing the GP, you're having the various checks, you're reporting all of the symptoms, then we do know now that the benefits certainly outweigh the risks from taking HRT. So I hope that answers.
I can jump in a bit about genetics. So as a non-geneticist, so someone who I can't even remember genetics from med school, genetics is really complicated, and your genome has so much complexity to it that it's not like there's a blue bit that says you're going to get cervical cancer, or a red bit that says you're going to get womb cancer. There are really specific, complex little bits in your DNA which in some cases might be familially transferred, but there's probably a lot of other factors that make you much more at risk of developing cancer, like the sort of lifestyle things and some medication and conditions that we talked about. So unfortunately, we haven't got good genetic testing apart from the BRCA testing to give you a clear message of what you're going to get cancer-wise. Most people have cancer in their family. There is, most of my patients will have a lung cancer or a, breast cancer or some different type of cancer. That doesn't mean you're going to get cancer yourself. So I think it's really important that we realise that that genetic testing isn't simple, and we have to sort of follow the guidance of the geneticists when they tell us who needs it. So at the moment, breast cancer is the only one that we really, and ovarian cancer is the only one that we sort of have a clear pathway for referring to geneticists. That will 100% change over the next 20 years. But where we are in science at this point in time, we don't have good testing for everything. So I hope that kind of makes sense with the genetics explained for my brain.
I think that's great. We've only literally got a couple of minutes left. I wanted to thank Rue for an incredibly powerful presentation, and say that we wish you all the very best. I think next week you said you start again, so we really do. And to Rebecca and Stacey, thank you so much. I've learned so much. It's been absolutely brilliant. And to our audience, who, as ever, we love you. And I just think the fact that you're so engaged and you put all these questions in the chat, please, everybody, keep coming back to Wellbeing of Women. Please donate. We definitely need your money. And yes, we will be sharing a recording of this, and it is available, I believe, on our website and also on YouTube. So you can share it amongst your friends and anybody else you want to. And really just to say, again, a huge thank you to my brilliant panelists and to all of you. It's been absolutely amazing. And I'm giving you 2 minutes back of your lunch hour, so you can go and do whatever you need to do. But no, it's been really fantastic. Thank you so much.
Thank you.
Oh, thank you for having us. And lovely to meet you, Rue.
Yeah, great. Thank you, everybody.